If the child already has a 3rd degree heart block, and then we look for is if there is extranodal disease. So is there myocardial involvement? Is there something called endocardial fibroelastosis, or is there hydrops? If these are present, then probably we will still consider glucocorticoids. Now, if you remember the first case, she had complete degree heart block. The child had complete degree heart block. However, because there was still some extranodal disease in the form of hydrops, we proceeded ahead to give glucocorticoids. If there is no extranodal disease, it's only expectant management. We should not go ahead and give steroids. It's unlikely to help. So for practical tips, in patients with unexplained 2nd trimester or early 3rd trimester miscarriages, please check ANA and anti-Rho titers. Now, preferably the anti-Rho should be checked by ELISA rather than doing a normal ANA profile, because the ANA profile can sometimes miss out on anti-Rho the anti-Rho antibody. So please check it by ELISA. And if it is positive, you should start HCQ at the earliest. That is the only proven therapy to prevent or reduce the chances of further complete heart block developing. And frequent monitoring of PR interval, preferably by a fetal medicine specialist or a pediatric cardiologist, is available. And a guarded prognosis always needs to be explained, because this is a dynamic situation and this can progress or this may revert. So a guarded prognosis and expected management is usually the way to go about it. Coming to the second point of my talk today, which is about the medications that we use in pregnancy and breastfeeding. Now, a lot of patients who having autoimmune conditions are usually in the reproductive age group, and they may be also on some medications. One of the common questions we get is, suppose when the patient becomes pregnant or is planning pregnancy, which ones do we need to stop, which ones we need to continue? This is a table which generally shows the medicines which are most all of these medications are safe to use in pregnancy, with small certain caveats. So if you look at it, the most commonly used medications which are safe are hydroxychloroquine, sulfasalazine, colchicine. Colchicine is uncommonly used in general in these patients. Azathioprine. So hydroxychloroquine, sulfasalazine, azathioprine, and tacrolimus, cyclosporin or tacrolimus. So these are the commonly used. Prednisolone is safe. However, there is chances of IUGR and maternal complications like diabetes, dysglycemia, etc., which needs to be taken care of. But by default, as such, they are not teratogenic. Non-steroidal anti-inflammatory drugs, COX-2 inhibitors like etoricoxib, celecoxib should be avoided. The others one like naproxen, diclofenac, they are safe in the first 2 trimesters. In the 3rd trimester, you should preferably stop them to prevent problems with the ductus arteriosus. Other biologics like tumor necrosis factors, these are less commonly seen, but in general the concept is that tumor necrosis factors like adalimumab, which is very commonly used nowadays, is safe in the first 2 trimesters. In the 3rd trimester, it should be avoided. And the last one is rituximab. Now again, rituximab is the need for rituximab should be discussed with the patient. If maternal indications for overwhelming disease activity is there, then it is required. Otherwise, preferably stop, because fetal hypogammaglobulinemia can occur if we give it in the pregnant mother. So that needs to be discussed with the rheumatologist. Now, the drugs which should definitely not be given. The topmost among the list is methotrexate, leflunomide, and mycophenolate mofetil. Absolutely contraindicated periconception and in all throughout pregnancy, and even in breastfeeding also. So amongst these, methotrexate should actually be stopped at least 1 month. Preferably, I generally follow 2 months. 2 months of stop and then plan a conception. Leflunomide, the drug stays in the body for up to 18 months due to enterohepatic circulation. And if the patient is on leflunomide, just stopping it for 1 or 2 months will not help. You have to give something called a cholestyramine washout. So unless you give a cholestyramine washout, 2 to 3 months of stopping does not work for leflunomide. Mycophenolate, again, teratogenic, absolutely contraindicated. Cyclophosphamide, exceptional circumstances, generally contraindicated. And the last one, which is JAK inhibitors, it is rampantly used these days, which is tofacitinib. For almost every sort of joint pain, people use tofacitinib. May or may not be indicated, but the fact is that regardless of the indication, it is contraindicated in pregnancy as well as in breastfeeding. They are incompatible. So this also needs to be kept in mind. Other medications like supportive medications that we use, tramadol, preferably avoided. COX-2 inhibitors, as I said, avoided. Warfarin, as we know, is teratogenic, should not be used. Direct oral and the newer anticoagulants, preferably avoided, and bisphosphonates to be avoided. So these are the medications which should be generally avoided or used if in pregnant patients or if the patient is planning pregnancy. Now, the third point of it, how we manage lupus in pregnancy. Now, I'll just give a short case which I had a couple of years back. So we had a 22-year-old lady who presented with a 2-month history of fever, rash, joint pains, and frothy urine. Evaluation revealed new onset SLE with lupus nephritis, class 4 on the biopsy with crescents. This is considered a very active and aggressive form of the disease. Now, she was started on pulse steroids, given 1 dose of cyclophosphamide, and she was strongly counseled against regarding contraception and the need for avoiding pregnancy in view of overwhelming disease activity. Unfortunately, she came back 7 weeks later with an increase in skin rash and a missed periods, and she was 5 weeks pregnant. Again, we strongly advise termination of pregnancy to this lady in view of active disease, both from the view of the mother as well as the fetus. The fetus was very unlikely to survive. However, the maternal threat is very, very high in such a case of an overwhelming active disease. However, despite all counseling, the family chose to continue the pregnancy. We had to manage with the best possible combination of pregnancy-safe medications, which is actually not standard of care, but this is what we best had. So we gave her steroids, we gave her cyclosporin, and we gave her azathioprine. Unfortunately, 4 weeks later, she presented with fulminant myocarditis, polycirrhosis, and succumbed to refractory shock. So this real case actually highlights the challenges of managing SLE in pregnancy and the need for aggressive counseling regarding the timing of pregnancy in these patients. So what are the effects of pregnancy on SLE? So pregnancy, particularly the puerperium, increase the likelihood of flare by around 40% to 60%. And the risk of renal flare, the renal worsening, is around 30% and is much higher if the disease is not already in remission. Vice versa, even SLE per se has effects on pregnancy, like there is an increased risk of spontaneous miscarriage, fetal death, preeclampsia, IUGR, preterm delivery, low birth weight, etc. Even quiescent renal lupus, if there is uncontrolled hypertension or proteinuria, is associated with poor outcomes. So the key here is actually intensive preconceptional counseling, explaining to the family how harmful an unplanned pregnancy can be in such a scenario. A rheumatologist should be involved in this whole preconceptional counseling process and subsequently after the confirmation of pregnancy. Why it is required is to have a baseline assessment prior to conception, in which we usually check for complements, dsDNA, clinically assessment, urine spot proteins, and once we are certain that okay, the disease appears to be in remission for at least 3 to 6 months, then we advise the patients, fine, we can now probably plan conception. But that needs to be a multidisciplinary approach, and the whole concept is to control flares adequately, have a sustained period of remission with appropriate medications, and then plan pregnancy subsequently.